Welcome to This Week in Anesthesiology. This week we are covering 9 notable papers spanning perioperative neurocognitive protection, advanced risk prediction in cardiac surgery, and evolving clinical practice guidelines. Let us dive in. We begin with a focus on perioperative neurocognitive outcomes, a major area of concern for our aging surgical population. Postoperative delirium and neurocognitive disorders represent significant complications after general anesthesia, and 2 recent publications address how we might better predict and prevent these events. In the British Journal of Anesthesia, researchers conducted a scoping review of 8 randomized controlled trials involving over 800 patients to evaluate the design and feasibility of cognitive rehabilitation. This strategy aims to increase preoperative cognitive reserve using computerized, multi-domain brain training before surgery. The review revealed a critical challenge. Patient adherence was highly variable, with 5 trials reporting very low adherence rates between roughly 9 and 40%. However, when supervised in-hospital or structured support was provided, adherence reached up to 94%. Crucially, in the trials where high adherence was achieved, cognitive rehabilitation demonstrated a clear clinical benefit, yielding an absolute risk reduction in postoperative delirium of approximately 10 to 16%. And an absolute risk reduction in postoperative neurocognitive disorders of 20 to 37%. While prehabilitation represents a proactive strategy, identifying which patients are at the highest risk remains a cornerstone of perioperative management. Addressing this need, a prospective observational study, utilizing data from over 1,400 patients undergoing general anesthesia, of whom 18% developed delirium, the investigators integrated heart rate variability parameters and electrocardiogram abnormalities with traditional clinical risk factors. The combined clinical, electrocardiogram, and heart rate variability model achieved the highest predictive performance, with an area under the curve of 0.73, outperforming models that relied on clinical or electrocardiographic data alone. When tested on an external validation set, the model maintained robust performance with an area under the curve of 0.84. The core predictors driving this model included age, physical status classification, operative time, arrhythmias, street segment abnormalities, and heart rate variability entropy. Together, these studies suggest that while advanced physiological modeling can help us identify high-risk patients at the bedside, structured prehabilitation programs may offer a viable therapeutic pathway to mitigate that risk before incision. Turning our attention to the cardiothoracic suite, managing bleeding and transfusion requirements remains one of our most frequent and complex challenges. In Anesthesia and Analgesia, a systematic review and meta-analysis of 19 studies involving over 9,000 patients evaluated the clinical effectiveness of acute normovolemic hemodilution in adult cardiac surgery. The analysis demonstrated that acute normovolemic hemodilution significantly reduced the overall incidence of allogeneic red blood cell transfusions compared to standard care, dropping the transfusion rate from 31.5% to 27.5%. This reduction was particularly pronounced when clinicians utilized crystalloid-based protocols and during on-pump surgeries. Interestingly, while matched cohort analyses confirmed this benefit, an analysis restricted only to randomized trials showed a non-significant trend toward reduction, highlighting some ongoing protocol variability in the literature. Importantly, the technique maintained an excellent safety profile, with no significant differences observed in postoperative hematocrit, fresh frozen plasma transfusion, renal dysfunction, myocardial infarction, stroke, or mortality. This pragmatic success in blood conservation contrasts with the ongoing challenges of predicting which cardiac surgical patients will experience severe bleeding. In an article in Anesthesiology, authors explore why bleeding risk in cardiac surgery still eludes us, despite the rise of artificial intelligence and machine learning. The authors argue that current predictive tools often fail because they prioritize statistical performance over clinical utility, rely on static variables rather than dynamic, time-varying clinical data, and fail to integrate seamlessly into real-time bedside workflows. To bridge this gap, future predictive models must focus on clinically actionable outcomes and dynamic clinical contexts, reminding us that prediction is only valuable if it directly guides timely clinical decisions. Beyond cardiac and neurocognitive management, several recent publications highlight key updates in clinical guidelines, Pharmacology, and Procedural Care. In the British Journal of Anesthesia, the European Malignant Hyperthermia Group has published its 2025 guidelines for the investigation of malignant hyperthermia susceptibility. These guidelines emphasize the essential educational loop that connects diagnostic workup to emergency rescue, ensuring that teams are prepared to act rapidly during a crisis. To complement these guidelines, a study in the same journal introduces a Bayesian updating method to estimate malignant hyperthermia susceptibility based on a patient's historical exposure to triggering anesthetics, offering a more personalized approach to risk assessment. In the realm of novel pharmacology, a paper in Anesthesia and Analgesia tracks the early clinical adoption and practice patterns of suzetrigine, a selective sodium channel inhibitor, in both inpatient and outpatient settings following its recent Food and Drug Administration approval. In postoperative transition management, a review in the Canadian Journal of Anesthesia discusses the safety, logistics, and clinical implications of deferring tracheal extubation to the post-anesthesia care unit, a practice that may optimize operating room throughput for select patients. Finally, also in the Canadian Journal of Anesthesia, researchers evaluate the clinical utility of an esketamine-propofol combination for elective cardioversion in patients with atrial fibrillation, exploring how this drug combination might offer hemodynamically stable and effective procedural sedation. If you only have time for one paper this week, make it the systematic review on acute normovolemic hemodilution in cardiac surgery. This study provides robust, meta-analytic evidence that a simple, low-cost blood conservation strategy can significantly reduce allogeneic red blood cell transfusions without compromising patient safety, offering a clear and actionable intervention for our daily practice in the cardiothoracic operating room. Here are the key takeaways from this week in anesthesiology. First, acute normovolemic hemodilution is a safe and effective method to reduce allogeneic red blood cell transfusions in cardiac surgery, particularly when using crystalloid-based protocols and during on-pump procedures. Second, cognitive prehabilitation shows clear efficacy in reducing postoperative delirium and neurocognitive disorders, but its success hinges on high patient adherence, which is best achieved through structured, supervised programs. Third, integrating heart rate variability and electrocardiogram data with traditional clinical variables significantly improves our ability to predict postoperative delirium at the bedside. Fourth, predicting perioperative bleeding in cardiac surgery remains a challenge that requires dynamic, time-varying models rather than static risk scores to be clinically useful. And finally, keep an eye on emerging clinical updates from the European Malignant Hyperthermia Group's 2025 guidelines to the early adoption of novel analgesics like suzetrigine. That's your roundup for this week in anesthesiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.